Navigating cancer screening recommendations can feel like a complex puzzle, especially when it comes to older adults. While chronological age often dominates discussions, a recent look into the American Academy of Family Physicians, or AAFP, guidelines reveals a far more nuanced approach. The key takeaway is clear. Life expectancy, not just a person's age, should be the primary factor in making screening decisions. Understanding this distinction is vital because realizing a mortality benefit from common screenings, like those for breast or colorectal cancer, generally requires a life expectancy of at least 10 years. This is due to a concept called lag time, which is the period between when a cancer is detected through screening and when treatment actually prevents a death. If a patient has a limited life expectancy, they simply won't have enough time to experience this benefit, even if their age falls within recommended screening ranges. Tools like the Lee-Schonberg Index or e-prognosis can help clinicians estimate life expectancy and guide these important conversations with patients. Beyond the question of benefit, there's a significant harm to consider: overdiagnosis. This occurs when screening detects slow-growing cancers that would never have caused symptoms or contributed to a patient's death. Overdiagnosis is especially prevalent in prostate, breast, and lung cancers among older adults. The unfortunate consequence is that these patients can undergo the full array of treatment-related harms, including surgery, radiation, and chemotherapy, for a condition that was never a real threat to their well-being. Turning to specific screenings, breast cancer screening for women 75 and older becomes a highly individualized decision with uncertain benefits. The U.S. Preventative Services Task Force, or USPSTF, issues an I statement for mammography in this age group, meaning there's insufficient evidence to definitively determine the balance of benefit and harm. Randomized trials simply haven't included enough women in this demographic to provide clear answers. However, the American Cancer Society, or ACS, suggests continuing screening as long as a woman has a greater than 10-year life expectancy, highlighting the ongoing debate and the need for patient-centered discussions. When it comes to prostate cancer, routine PSA-based screening is generally not recommended for men aged 70 and older. Both the USPSTF and the American Urological Association, or AUA, advise against it. This shift reflects a clear understanding that for older men, the harms of screening often outweigh any potential benefits. Screening frequently leads to the overdiagnosis of clinically insignificant cancers, and treatments for these can carry significant risks, including erectile dysfunction and incontinence. Notably, the PROTECT trial demonstrated that for localized prostate cancer, active monitoring resulted in similar 15-year mortality rates as radical prostatectomy and radiotherapy. This powerful finding truly underscores that aggressive treatment for screen-detected cancers may not offer a survival advantage while causing definite harm. In contrast, cervical cancer screening has clearer guidance for when it can safely stop. Women over 65 can discontinue screening if they have no history of high-grade dysplasia, defined as CIN2 or higher, and have a history of adequate prior screening. Adequate screening is typically defined as 3 consecutive negative cytology or PAP tests, or 2 consecutive negative HPV co-tests within the previous 10 years, with the most recent tests performed within the last 5 years. For such patients, the risk of developing a new, persistent, high-risk HPV infection that progresses to cancer is extremely low. For colorectal cancer, screening for adults between 76 and 85 is a selective, individualized decision. The USPSTF gives it a Grade C recommendation, indicating a small net benefit that decreases with age. It's important to consider that procedural risks associated with direct visualization tests like colonoscopy, which include perforation, bleeding, and periprocedural cardiovascular events, increase significantly in older, frailer adults.
while a colonoscopy might be reasonable for a healthy 76-year-old who has never been screened, less invasive stool-based tests, such as a fecal immunochemical test or FIT, might be a safer alternative for older, frailer patients with comorbidities, if screening is pursued at all. Finally, lung cancer screening eligibility extends beyond just age and smoking history. While annual low-dose computed tomography, or CT, is recommended by the USPSTF for adults aged 50 to 80 who have a 20-pack year smoking history and who either currently smoke or have quit within the last 15 years, a critical but often overlooked criterion remains. The patient must also be a candidate for curative surgery or treatment, such as a lobectomy or stereotactic radiation. This ensures that screening leads to actionable, potentially life-saving interventions rather than simply detecting cancer that cannot be effectively treated. Ultimately, these guidelines emphasize moving beyond a one-size-fits-all approach to cancer screening. Instead, the focus is on personalized, evidence-based decisions that prioritize a patient's overall health, life expectancy, and individual values, ensuring that the potential benefits of screening truly outweigh the potential harms.